Welcome to the deep dive.
Okay, today we're jumping into a really fascinating, maybe sometimes a bit overwhelming topic, aphasia.
Mm-hmm.
We've got this stack of material here, all focused on this acquired communication disorder. And it's way more than just, having trouble talking.
Absolutely. It's really a window, isn't it, into how language is wired up in the brain?
Right. And how easily that wiring can get damaged.
Exactly. So our mission really is to map the symptoms we see to the specific brain structures involved. Aphasia hits those core abilities: speaking, understanding speech, reading, writing, all of it.
And the key thing you mentioned before we started rolling was location, location, location.
That's the fundamental piece, where the damage, the lesion occurs in that language circuitry. That dictates the type of impairment you're going to see.
So imagine a patient, or maybe their family, notices this sudden, probably terrifying inability to communicate. The clock's ticking. How do we quickly diagnose it? Or at least start to figure out the type? Yeah, speed is crucial. It really starts with careful observation, get the history, maybe the family reports. They just can't communicate properly. Then the exam starts.
What are you looking for specifically?
We're looking for, obviously limited speech output maybe.
Yeah.
Or perhaps the speech is fluent, but just sounds bizarre, nonsensical.
Okay.
We check comprehension. Can they follow commands? Understand questions? And then a really key diagnostic tool is repetition.
Repetition. Can they repeat words or phrases, you say?
Exactly. That ability or inability helps us slice the pie different ways.
Okay, let's unpack this then. You mentioned sort of two big buckets to start with. Let's go with the first one, the kind that affects actually getting the words out, the expressive side.
Right. Expressive aphasia. That's fundamentally an impairment in producing language.
Yeah.
And the way it looks is often quite striking.
How so?
Well, you'll see very short sentences, often poorly put together grammatically. The person might be visibly struggling, searching for the right word.
On writing too, I assume.
Oh, yeah. The writing difficulties usually mirror the speaking problems. It's an output issue across the board.
The speech itself, does it sound different? Like physically?
Definitely. The hallmark is what we call non-fluent speech. It loses that smooth, natural flow. Grammar often breaks down. The rate, the rhythm, it's all abnormal.
You mentioned something memorable before: telegraphic speech.
Ah, yes. That's a great way to picture it. Think about sending an old telegram where you paid by the word.
Right, you'd cut out all the little words.
Exactly. You use mainly the core nouns and verbs. Go store milk, that kind of thing. All the connecting words, the articles, prepositions, they often disappear.
So the meaning is in there. They know what they want to say,
Mm-hmm.
but the delivery system is broken.
Precisely. And that leads to something really important, clinically speaking.
Which is?
The patient's awareness. People with expressive aphasia are typically acutely aware of their difficulty. They know they can't speak properly.
And you can see that.
Oh, absolutely. You often see intense frustration, anxiety, sometimes even despair when they try to communicate because they fully understand that their thoughts aren't coming out right. It's incredibly distressing for them.
Okay, so that awareness, that frustration points towards expressive problems.
Mm-hmm.
But you said there are subtypes within that. How do we tell them apart? You mentioned that test.
Repetition again, it's the key differentiator here. So if the patient has that non-fluent speech and they are unable to repeat simple words or phrases we give them,
Then what?
then we diagnose Broca aphasia.
Broca aphasia.
Mm.
And that inability to repeat, what does that tell us about where the damage is?
It points pretty clearly to the Broca area. That's in the dominant hemisphere, usually the left, in the posterior inferior part of the frontal lobe.
Okay.
That area is crucial for planning and producing speech movements. Damage it, and you disrupt both spontaneous speech and the ability to repeat what you hear.
But sometimes a patient might have that same struggle, that non-fluent output, but they can repeat. They can echo back what you say, even if they can't form their own sentences well.
Yes, that happens, and it changes the diagnosis. If repetition is intact, despite the non-fluent speech.
Then it's not Broca's.
Correct. We call that transcortical motor aphasia. The ability to repeat tells us the core Broca's area itself and the connection to the hearing centers is likely okay.
So where's the problem then?
The damage is usually nearby, often anterior or superior to Broca's area. It's like the main production factory is fine, but the roads leading into it, the pathways involved in initiating and planning speech, those are damaged.
Makes sense. Okay, that covers the expressive non-fluent side where patients are often very aware and frustrated. Let's flip to the other side, receptive aphasia, loss of comprehension. This sounds like a whole different ballgame.
It really is. And the contrast in awareness here is, well, it's profound. Receptive aphasia means a major problem understanding spoken language and often reading, too.
But how do they speak? If Broca's is okay.
Ironically, their speech output is often completely fluent, effortless even, sometimes rapid. The grammar might sound perfectly fine.
Wait, so they sound normal, but they can't understand you.
They sound fluent, but the content is the problem. It's often meaningless. We sometimes call it a word salad.
Word salad.
Yeah, like you just tossed a bunch of words together randomly. They might say something like, "The blue door slept over the cloud," with perfect intonation, but it makes no sense.
Wow.
We also see what are called paraphasic errors. They substitute words, maybe a related word like table for chair, that's a semantic paraphasia, or a word that sounds similar like pog for dog, a phonemic paraphasia.
Okay, so fluent but nonsensical speech. What about their awareness? You said it was different?
Dramatically different. Patients with receptive aphasia often lack insight into their deficit. They genuinely don't seem to realize what they're saying is nonsense.
Seriously?
Yes, and they also don't grasp that they aren't understanding you. So if they get frustrated, it's often because they think you are the one not making sense or not understanding them.
That's hard to imagine. It suggests that Wernicke's area, the comprehension zone, is also involved in monitoring our own speech.
It seems deeply involved, yes. That lack of self-awareness is a key clinical feature.
Okay, let's apply our test again. Repetition. If this patient fluent but nonsensical speech, poor comprehension if they cannot repeat.
Right. Impaired repetition plus poor comprehension. That locks it in as Wernicke aphasia.
And the location.
That points directly to the Wernicke area. Again, usually left hemisphere in the posterior part of the superior temporal lobe. That's the brain's main hub for processing the meaning of language.
But just like the motor side, there must be a version where repetition is spared.
There is. What if they have the fluent nonsense, the poor comprehension, but they can repeat words and phrases surprisingly well?
What's that called?
That's transcortical sensory aphasia. Again, preserved repetition is the clue. It means the direct pathway for hearing words and saying them back is working.
So the lesion isn't in Wernicke's area itself.
Probably not directly in it, or maybe spares the immediate connections needed for that repetition loop. It's nearby, causing the comprehension problem, but the auditory motor feedback loop for repeating is intact.
Okay, this is starting to form a map. Broca's for making speech, Wernicke's for understanding it. What about the connection between them?
Ah, yes. That brings us to another important type, conduction aphasia. This one is fascinating because it really highlights the importance of that connection.
The wiring itself.
Exactly. The lesion here specifically affects the arcuate fasciculus. That's the big nerve fiber bundle, the highway, that connects Wernicke's area to Broca's area.
So the two main centers might be relatively okay, but the communication line between them is cut. What does that look like?
Clinically, it's quite distinct. Speech is generally fluent, maybe with some hesitations or errors. Comprehension is usually pretty good, only mildly impaired. They understand you.
Okay. So what's the main problem then?
Repetition. They have a severe deficit in repeating words or phrases, much worse than their ability to speak spontaneously or understand.
Because that task specifically requires transferring info from Wernicke's to Broca's.
Precisely. That direct pathway is damaged. So you also see a lot of phonemic paraphasic errors, sound substitutions as they try to spook, especially when trying to repeat. The signal gets garbled in transit.
It really shows how networked language is.
Yeah.
Okay, and then there's the most devastating type.
Yes, unfortunately, that's global aphasia.
Global meaning,
Yeah,
everything.
pretty much. It's the most severe form. It results from a very large lesion, usually a big stroke, that knocks out both Broca's and Wernicke's areas, and often the connections between them two.
And the clinical picture.
It's profound impairment across the board. Minimal or no speech output at all. Can't write, can't comprehend spoken or written language, and absolutely cannot repeat. It's a near total loss of language function.
Devastating. Okay, so we've mapped the types of aphasia to locations based on symptoms like fluency, comprehension, and crucially, repetition. Now, here's where it gets really interesting.
Yeah.
How do we figure out the why? What caused the damage?
Right. We've localized the what and where. Now for the why. And the first big clue here is timing. How fast did the symptoms appear?
Okay, so let's take the sudden onset first. Comes on out of nowhere, minutes to hours.
Sudden onset screams vascular event or trauma. So stroke, either ischemic or hemorrhagic or traumatic brain injury, TBI. Those are the prime suspects.
And you mentioned earlier, aphasia usually comes with friends, right? Other deficits.
Almost always, especially with stroke or significant TBI. Because the language areas are in the cortex, damage there often affects nearby areas. So you look for associated focal signs, weakness on one side, numbness, vision problems.
You called aphasia a cortical sign. What does that mean practically?
It means the damage is in the outer layer of the brain, the cortex, not deep inside structures like the brainstem or thalamus. So if someone has aphasia, you know it's not a deep lacunar stroke, for example. It helps narrow down the possibilities significantly.
And if you see aphasia plus, say, weakness on the right side of the body,
Ah, that's the classic pattern. Aphasia almost always involves the left hemisphere. The motor cortex controlling the right side is right next door. So aphasia plus right-sided weakness, maybe right facial droop, right-sided numbness, maybe even loss of vision to the right side.
that points to.
That strongly points to a stroke in the territory of the left middle cerebral artery, the LMCA.
The LMCA. Why is that artery so critical?
It's the main blood supply for the vast majority of the lateral side of the left hemisphere, which includes Broca's area, Wernicke's area, the arcuate fasciculus, and the motor and sensory strips controlling the right face and arm.
So one blockage takes out language and right-sided function together.
Very commonly, yes. It's incredibly important to vascular territory.
And imaging, like a CT or MRI scan, would confirm this.
Definitely. In a stroke, you'd see an area of infarct, dead tissue from lack of blood, or
Sure.
hemorrhage, bleeding. With TBI, you might see bleeding in different spaces, subdural, epidural, maybe skull fractures, contusions. The imaging nails the acute cause.
Okay, that covers the sudden onset. What about the other scenario? The aphasia creeps up slowly, gradually, over months or even years.
Gradual onset completely changes the differential diagnosis. Now we're thinking about things that grow slowly or things that degenerate slowly.
How do we sort that out?
Again, we look for associated signs. If the gradual aphasia comes with other focal neurological problems, maybe new seizures, persistent headache, perhaps some subtle weakness or facial droop, signs of increased pressure in the head like optic disc swelling,
Then you suspect.
then you have to strongly consider a left hemisphere mass lesion, something growing and compressing or infiltrating the language areas,
Yeah.
like a brain tumor, primary or metastatic, or maybe a chronic brain abscess.
And imaging confirms that too.
Yes, an MRI with contrast is usually the test of choice there. It will show a space-occupying lesion if one is present.
But what if? What if the language decline is gradual, but it's happening in isolation? The only thing getting worse is their language. No weakness, no seizures, no headaches, just language dissolving.
Ah, that specific pattern points towards a neurodegenerative condition called primary progressive aphasia, or PPA.
Primary progressive aphasia, so it's a form of dementia.
It's considered a clinical syndrome, often an early presentation of certain types of dementia. Yeah, specifically diseases like frontotemporal dementia, FTD, or sometimes Alzheimer's disease can present initially or even predominantly with just a progressive loss of language function.
And what would an MRI show then? Not a mass, presumably.
Correct. In PPA, the MRI typically shows atrophy, meaning shrinkage, of brain tissue. And importantly, that atrophy is usually focused predominantly in the left hemisphere language region, maybe the frontal lobe for non-fluent PPA, the temporal lobe for semantic PPA, or the parietal lobe for logopenic PPA.
So the brain tissue itself is degenerating in those specific language zones.
Exactly. It's a slow, relentless process targeting the language network.
Wow. So, okay, let's pull this all together. We basically built a diagnostic map, haven't we?
I think so. You start with the symptoms. Is it fluent or non-fluent? Is comprehension intact or impaired? Can they repeat? That tells you the type of aphasia, which points to the location of the damage: Broca, Wernicke, the connection, or widespread.
Right. Location dictates type, and then the timing.
Then the timing, sudden versus gradual, combined with any other neurological signs, tells you the likely cause. Sudden points to stroke or TBI. Gradual with other signs points to a mass. Gradual language loss alone points towards PPA, a neurodegenerative process.
It's a really elegant clinical logic when you lay it out like that.
It is, and maybe the most, human takeaway from all this is that difference in awareness we talked about.
Yeah, between the expressive and receptive types.
Exactly, that raw frustration of the expressive patient who knows they can't communicate versus the, frankly, unsettling unawareness of the receptive patient whose reality seems warped because they don't recognize their own errors or comprehension failure.
It really highlights how different brain regions don't just handle mechanics, but shape our actual experience.
Absolutely. It shows how integral Wernicke's area, for instance, is to self-monitoring, to our sense of whether we're making sense in the world.
So here's a final thought to leave people with. We established that aphasia is a cortical sign, and the LMCA territory is critical, often causing aphasia and right-sided motor deficits together.
Hmm.
If that one artery supplies both our complex language ability and basic motor function for half the body, what is that interconnectedness, revealed so starkly by a stroke? Tell us about the deep link between what we often separate as mind, our ability to communicate thoughts, and body, our ability to physically act in the world.
That's a deep one. It suggests that division is perhaps more artificial than we think.
Maybe language isn't just thought, but also a form of action, deeply tied to the same neural real estate, something to chew on until our next deep dive.